philologist, year 18, 19, and 22, with many well-known books on ultrasound. Is Dr. Erica, she will be online with us on Zoom. She's okay?
Yes.
Dr. Erica, how are you doing? Yeah,
Thank you.
I'm Khalid, yes. Okay, so you will present your presentation. We are hearing you and seeing you well, so if you want to, you can start.
So thank you so much for the invitation. I was very touched when you approached me when I was in Cairo beginning of the month. I can't be there again, I'm sorry. It's a lovely place. And thank you for inviting me. So I have no conflict of interest with this presentation. I know you are all radiologists, and I expect you to know how to work with the ultrasound device. So I will focus on provocation maneuvers in the veins. In the arteries, you have already your flow, but in the veins, you have to provoke the flow. And on the exploration of the great saphenous vein, because this is the mostly affected illness. And I can tell you from experience of Peru in Lima, where I was having a workshop for 2 days in 2017, I noticed that radiologists and surgeons don't speak to another about the findings and about the consequences. And I can only invite you to do so, because the surgeon profits more from your results if you know how to describe it, and you profit from the exploration if you know what the surgeon is needing. So this is a good idea perhaps to put persons together. So flow provocation maneuvers are important because the patient, especially if you explore him standing, which is the normal way to do with the varicose veins, in the standing there is very little flow in the veins. And so there are lots of maneuvers, and always when you have lots of things, nothing of these things is the perfect one. So you have to know all of them and decide for case. Valsalva, you know it, you have to take in the breath and then express flow, but the people moves, the people aren't able to do so. So this straw maneuver is a very good idea. Straws are cheap, and you just fold it and have the patient blowing inside, and then you have a constant pressure in the abdomen, which would prompt a reflux if present. The manual compression and release, I will go to them in detail, but it's surely the manual release is the most often applied. The Wunderhofer maneuver is the toe elevation. And then you have this weight transfer maneuver called Paraná maneuver, but you always have the patient moving, and this is sometimes difficult. And the so-called dependency maneuver. Valsalva, you all know it, and as I told you, this blowing into a straw is really a good option to have a continuous same pressure thing, and the people aren't fainting, because if you do Valsalva, the standing person, after 3 or 4 times they are fainting and I can't stand it. The manual compression and decompression of the calf is surely the most often applied, also me, because I can talk to the patient in the meanwhile and I can go on with my exploration, and the patient doesn't have to understand what I want from him. But it is not a physiologic flow, and sometimes if there is pain in the calf, it is painful, and it depends on the relationship between hand and leg. Like this is the example, my daughter pressing my husband's leg and my husband my daughter's leg. Of course, the bigger the hand in relation to the leg, the more flow you will express, and possibly in this case you won't have any flow. So you have to be aware of the problems the maneuver could have in practical cases. Franceschi developed the so-called Paraná maneuver because he described it in Paraná in Argentina, and he pushed the patient when he's sitting back of him, and pulls him when he's in front of them, and you have a big contraction of the gastrocnemius veins for staying upwards, and this provokes a real large flow. But people get aware of it, and in my experience they start moving and defending, and so this is perhaps not such a good idea. So I tried to make an evolution of it, which was described 2000 in a paper, and it was called Wunderhofer maneuver, and now it's called toe elevation. And you can elevate the forefoot or contract the toes, and then you have a repeatable physiologic flow. And normally people understand this maneuver and do it easily. Like here you can see the flow provocation. Do you see the video? I hope so. This is the person elevating the toe, and you see there is a large reflux. Here again, just pay attention, flow, elevation, and large reflux in the vein. And this is a very good possibility to have always the same flow measurement. This is the place where the side branch exits. And now we go a little bit deeper with the device, and there is no longer a reflux. You see, it is a antegrade flow and no reflux. This is a very easy to do maneuver. And one I will bring to your heart, hopefully, is a thing Mr. Latimer in London and me developed simultaneously. Sometimes you say in Germany, two idiots, same idea. Because sometimes you have patients with a varicose vein and a dilated saphenous vein and no reflux, no matter what you do, no Valsalva, no compression release, nothing. This is the case, for example, here you see there is a varicose vein, there is a slightly enlarged vein. And if you put the patient recumbent with the leg up 20 seconds and then put him again back to staying, this is exactly the same vein, but just after laying down and standing up. And sometimes you miss a varicose reflux if you don't do this. I mean, I do it like twice a month, and I see very, very much patients, as you can imagine. But sometimes you have a discrepancy between what you expect and what you find. And then this is a real good idea to have a look. If you compare, this is after long standing, and this is after the dependency maneuver, and you have obviously a big difference. And this is why I brought it as a video to you, because this is really a very important take-home message. There is no flow with provocation maneuvers, and then the lady lays down. I've cutted the film, obviously I won't be here 20 seconds waiting. And then she gets up again. And if you have to remember where to position it, and it flows and flows and flows, and it can take 20 seconds, 2-3 minutes flowing back. This is very interesting. So we come to the reflux duration, because there is a little misunderstanding in literature, as for my understanding. Nikos Lavropoulos did a real huge work looking at healthy people and defining that in case of healthy people, this short reflux to close the valves is always less than 0.5 seconds. And then we phlebologists said, okay, everything which is longer than 0.5 seconds is reflux. And this is, as to my knowledge and as to lots of colleagues in the meanwhile, not the correct thing to think. So I made an evaluation to validate the Munster maneuver, comparing it to the manual compression of the calf. It was a part of PhD of a colleague, Mr. Habenicht. We measured the reflux duration, and we randomized if we first do the Munster maneuver or first do the calf compression, because of course if it's just depleted, possibly the next time it won't be so much. And we made a little graph with 13 healthy, which obviously were below 0.0, 0.5. And this is the length in seconds for manual compression, and this is the length in seconds for compression of the calf. And if you have the cutoff here of 0.5 seconds, you see only one of patients with real clinical varicose veins were below 0.5, but in the other kind of measure was below, over 2 seconds. So I would always recommend to use at least 2 maneuvers, those you prefer, knowing that you could do dependency any case, and then evaluate the patient with at least 2. And for me, these cases were all not so ill. The good ill patients were these ones, and all those that had less than 1 second in one maneuver had also in the other maneuver more than 1 second. So for me, the cutoff to decide to if the vein is really incompetent for the superficial leg veins is 1 second. And it is the same like the deep veins, which are also defined to be incompetent if the reflux is more than 1 second. Okay, now let's come to the great saphenous vein, because we have a little short of time, I know. And I want to show you a picture from clinics. The great saphenous vein is a thing running here. But these tributaries are not the great saphenous vein. Great saphenous vein runs inside a duplication of the fascia and can't be like this, can't be twisted like this. So this is always a tributary, and the great saphenous vein will be refluxing from the groin to here and then give this tributary. First step is the evaluation of the saphenofemoral junction. You know all the anatomy, the common femoral vein, the common artery, the great saphenous vein, the tributaries of the groin and the valves, they all have. And then we have the cranial tributaries and the pudendal medial tributaries, which play an important role in the physiology of the reflux. And then we have accessory anterior and accessory posterior veins. The posterior normally is a little bit further down in the leg, so the anterior is the one most important for pathology. And we have situation with competent valves, where we have antegrade flow in both. And of course, the one draining from the epigastric vein will be footwards, but physiologic. This is very important to have in mind. And then if we have a reflux here in the great saphenous vein, today we have to know where it comes from. I will come back to that later. Most often it is a so-called axial reflux, and it comes from the deep vein, crossing both incompetent valves and going down the great saphenous vein. This is so-called axial reflux, and terminal and preterminal valve are incompetent. In ultrasound, this is a longitudinal scan. We see it like this is the femoral vein, this is the great saphenous vein in the groin, entering the saphenous deep vein. We have an anterograde flow if you compress, if the patient puts up the toe. And when we decompress or the toe goes down, we have a reflux from the deep vein through the terminal valve, through the preterminal valve here, out into the leg. This is reflux curve. Here goes the toe elevation, then the toe relaxation. In the elevation, we have an inflow. In the relaxation, we have an outflow. And we measure this at the very point of the ostium, at the very point where the saphenous vein enters the deep vein, to be sure that the terminal valve is the one incompetent. So having learned this, we have other situations where the reflux comes from a tributary, not from the deep vein, and the terminal valve, as you see here, is completely competent. So you have no reflux from the deep vein, but from a tributary. And this is important because if you treat the vein at the leg level and they have a pelvic reflux source, I am not inviting you to treat the pelvic reflux source in any time, but you have to inform the patient that probably the recurrence rate will be higher because you aren't treating the origin of the reflux. This is so-called paraostial or non-axial reflux, which is competent terminal valve, incompetent preterminal valve. And in the image in the ultrasound, it is completely different. You see in the systole, the flow goes in from the superficial to the deep vein. And in the diastole, there is no exiting here. It is a reflux from the tributary of the groin inside the great saphenous vein. And why is this so important? If you just look at the new published guidelines, clinical practical guidelines document from the European Journal of Vascular and Endovascular Surgery by Marianne de Maizière and co-authors, they say that 27% of the recurrences are found by a pelvic reflux. So this is important to tell the patient and perhaps to focus on other treatment options to allow possibly the endoluminal heat treatment allows a drainage of the pelvic reflux. So this is all speculation because nobody in no study did look at this prior to treat the patient. So we have no idea if we could avoid these recurrences. And this is what I'm saying here. I'm claiming to say, please document which reflux source has the patient, so to make a checkup for your own results, but also in context of trials. Only in the CHIVA trials we are very keen on this because the result is, and the technique is completely different depending on the reflux source. But if you make stripping or endoluminal treatment, you have to be aware of the reflux source so to analyze the results. Just as a remembering of this, we have here this situation, tributary great saphenous vein and deep vein, and this is a systole where the flow goes from superficial to deep. This is the diastole where we have no reflux from the deep vein, no, only from the tributary. And this is the cross-section of the same patient. Here is no reflux. It is only from the tributary. And this is very important as indication for future thinking of how to treat patients. This is, again, a comparison. Normally, those with an axial reflux have larger refluxes, have larger varicose veins than if it is the tributary. So now we have seen from where the reflux can come, and then we have to see to where it drains. It can be axial, it can be cranial, or it can be from both sources. And then we have to analyze if it goes down here, if it only in the great saphenous vein, if it goes down the accessory vein, or it goes down both. So you have a big possibility of options to evaluate. And there is a wonderful work by Zollmann in the Journal of Vascular Surgery, but I took it out because I only have half an hour, which is a long, long time. I'm very glad I could talk so long, but this would be taking too long. So again, the standard is standing position. We have to see the morphology in the groin in longitudinal and cross-section just to see every tributary entering. We have to have a look in a color duplex, always, because it helps us to find the things more quickly. But we have to document in PV mode. I mean, sometimes I make a documentation if this wonderful paraosteal flow and so on, but if you want to have a documentation that the vein is incompetent, one second image of one flow situation is not enough in color. You have to have this reflux curve showing the length of the reflux for documentation. Well, I've said at the end of the saphenofemoral junction, you have to know the source of reflux, the path of the reflux. And of course, you have to see if there are lymph nodes there, if there are current or older thrombotic changes, if there have been previous treatment, and so on. This is, of course, another path you have to be aware of. This is the study I mentioned, where they found that this axial reflux is in 2/3 of the patients, and these patients were already scheduled for surgery. So this is not a view of all the people coming in, but those scheduled for surgery of great saphenous vein had 2/3 of them a reflux from the deep vein, 8% both deep vein and cranial, and 21% had only a reflux from the cranial reflux, and the terminal was competent. So we aren't talking about a very seldom thing. 1 of 5 patients coming to surgery have this situation. Now I come to the path of the saphenous vein, which runs here at the leg from the inner ankle and makes like a deflection here at the knee fold, and then goes up to the groin. And you have a fascia. Between the muscle fascia and the fascia saphena, the vein is like hidden inside. Saphenos is from the ancient Arabic and means hidden. And you will never see a tortuous saphenous vein or a meandering, because it is fixed in this compartment. And this is the compartment painted. This is copied from Caggiati, who described this in the modern time, because the ancient phlebologists, also the Egyptian ones, had already known this. And I love it to talk to Egypt, showing the Egypt eye. I have this by a courtesy of Alberto Caggiati. And this is the classical saphenous vein cross-section at the mid-thigh, where you have the muscles, the muscle fascia here, the saphenous vein, the saphenous fascia, the skin here. And there are this little fascia you also have in the fat tissue. And sometimes you see these little ligaments here, which are fixing the saphenous vein. And Caggiati also, with Ricci, defined the paths. Normally, it is IE form, one, starting here, going down, or anatomically, of course, other way around. And you have, at all the levels of the leg, you have the Egyptian eye with this shape. Sometimes you have an additional superficial accessory vein, which in radiology earlier was seen as a doubled great saphenous vein. But of course, if you have the honor to have a duplex, you can exactly see this one is the saphenous vein and this one is the accessory vein. And this is an MR and color CT. I don't have to explain you. This is the saphenous vein, and these are all these concomitant veins, and this is the accessory superficial vein. And this situation is in 26% of patients. It is not so little that you find an accessory vein running parallel to the great saphenous vein. And then you have the empty eye, the blinded eye, where this vein exits the fascia, and then you have a rudimentary rest of a plastic rest of the saphenous vein, and this is a tributary extrafascial one. And if you look at it in ultrasound, you see like the vein here, and then here is the compartment without any visible vein, and this is the path. This is I sometimes say an extraluminal saphenous vein, but this is not correct because it is not a saphenous vein. Here is always a rudiment. This is always an accessory superficial vein. So this again these are plastic segments. Here you have the compartment which is empty, and in cross section you see this perfectly normal, and this one, and the compartment is empty. And this is the differentiation. Sometimes they were very keen at the beginning of ultrasound to define which is hypoplastic and which is it's aplastic. But it has shown that there is no differentiation. If you see any lumen, there is a saphenous vein, and you can deal with it. This is the hypoplastic segment. So the real duplication of great saphenous vein occurs only 1%. And this happens when inside this compartment you see two eyes, two pupils, and they are connected with a segmentary ligament. And this is really the 1% of real duplications of great saphenous vein. And if you look at the old textbooks, they talk about 27% duplicated saphenous veins, and this corresponds with the real doubling with 1% and the accessory saphenous vein in 26%. If you do not know what you treat, you cannot evaluate your findings. This is what I told you in the first point. So if the recurrences after high ligation stripping with preoperative cranial reflux might result in neovascularization by non-drained pelvic reflux. And reflux into the accessory anterior vein after endonominal treatment is a possible path for the still existing pressure in the groin into the stump. So we have to consider this in future to evaluate the results of our working. So possibly axial reflux is best treated closing the saphenofemoral junction, and cranial reflux is best treated closing the great saphenous vein distal to the preterminal valve to allow a drainage of this reflux towards the deep vein. This is pure logic, but nobody can answer because nobody studied. And this is my request. I'm only working in an office. I don't have a university behind me. I can't do this study, and I would love if the study is ongoing and starting would reconsider this. I've skipped the perforating veins, I skipped the tributaries because the time is short, and I think I've run out of time already. So if you want to know a little bit more, I make a little bit of advertisement. We published a duplex ultrasound book here in Germany already 2006, and now the third edition. And 2014 we had the second edition was translated, and I had Chris Latimer and Nick Morrison as co-editors helping me with the English and the international interesting things, and it is still available as online or as book by Springer. And now I want to thank you and invite you all to join if you are interested in the European Venous Forum meeting next year in Berlin. Thank you very, very much, and I hope I didn't go too quick and you could understand something. Thank you.
I would like to thank you, Erika, for this wonderful presentation. I think on my behalf, myself and behalf of the audience, you have illuminated and tackled many dark spots that we face as radiologists when doing examination in the varicose veins. Are you still with us?
Yes, I'm here.
So, if you have any more time to take some questions from the audience and from the panel.
Of course, I'm here.
Yes. So on myself, ready. So I want to ask you about all provocative techniques. I know that we here in Egypt we are using the Valsalva maneuver, maybe the decompression techniques, but the two techniques is very reliable, as you're saying that we can use it in a reliable way to reach a final diagnosis.
Yes. I think it is important to do Valsalva and compression of the calf, and compression of the calf is obviously the most easy one.
Yes.
But sometimes you don't move the blood with this, And then you have to know that you could either push the patient or you can have him elevating the toe. This is very, very easy to do.
Yes.
And if it's mostly it is the slightly fatty women with this slow reflux where I do the dependency maneuver, because I don't know why the drainage is so poor in the perforators at the calf that they fill the vein and there is nothing moving. So you don't have to do it every day, but you have to know that this exists to come back to it when you stand before a vein and say, it should be refluxing, but that nothing happens.
Yes, we face all this problem. So another question. So another question about the recurrency in the new vascularization. So we all face the problem that we have a recurrence in the great saphenous vein, but we cannot detect the actual source of this. So it's a common problem me and my colleagues are facing.
Yes, there you have two situations. You can sometimes just the surgery was not good. We have to say like this.
Yes.
And so I differentiate between there is a stump with the valves. If after surgery of stripping, for example, there is a stump with valves inside, they didn't go to the deep vein.
Yes.
So they have to redo the crossectomy, or I often foam them because it is easier for the patient and they're not recutting in all these scars. If the stump is very long, nobody was even near to the place.
Okay.
But if the stump is short, you can do it with foam. Then you have the question: are there lots of little tiny vessels?
Yeah. And lymph node in the lymph nodes and everywhere you have new vasculature everywhere.
Yes, I know. And my experience, I did a study with the University of Bochum here in Germany. When you have this lots of tiny vessels and you look accurately, you find that the flow is not coming from the deep vein, but it's coming from pelvic refluxes. This is how I came to the idea that these neovasculates are not from the deep vein, but are from non-drained reflux from the pelvic insufficiency. And then you have to go down, and you see that the great saphenous vein wasn't taken out. And you find lots of, if the great saphenous vein is not taken out, you have lots of physiologically inflowing veins. Yes. And as they cannot go out upstairs in the groin because this was closed, it has to generate a reflux. I say it's a reflux generated by the physiologic drainage of the vein. And sometimes you keep searching for a reflux source, and it is just the healthy collaterals that are draining into it. And the most stupid situation, excuse me for the word, is when the saphenous vein is really eliminated and the patient has lots of spiders and reticular veins. And we say here in Germany that this is a failure of drainage after you have taken out the saphenous vein. There are a lot of tiny veins, but you don't see the reflux source. And I personally don't look for it. I scan at the typical perforating vein sources. Often you have a dot perforator or a hunter perforator feeding this, but if you don't have, you can make a sclerosation and it's okay. So if you're sure it doesn't come from the groin, the saphenous vein is gone, and there is no perforator, you have this lots of tiny tributaries, and nobody will treat that surgically. So nobody needs to know the exact source. You can make
so you have to form it for your own solutions. You have to form it. Yes. So, Dr. Karim,
first of all, thank you very much for the very elegant and brilliant talk. So, thank you very much. I want to ask you: do you routinely do genital Doppler for patients, especially those with extraaxial varicosities?
No, I don't do this because in Germany we had some cases of how do you say? When doctors misuse the patients, and this is strange when you start doing genital explorations because of the history we had in the last 20 years. But besides, I think this is only necessary in patients with a pelvic congestion syndrome. Of course, if I see the veins coming down the labia, I ask, do you have pain in the sexual intercourse? Do you have pain when you have your bleeding and so on? And if they say, if they deny this, my experience is that I position them with the legs aside, and I make a foam therapy directed upstairs. I mean, I puncture the veins and inject towards the labia. Definitely. And the first time I did this, I was very, very I was in a fear that I would provoke pain with these
injections, yeah.
Injections, or with the thrombi that happen, the sclerothrombi. But curiously, there are I've never seen sclerothrombi in these labial veins. And I puncture in the upper leg and put the foam upstairs. And I'm very surprised this works perfectly. You don't have to touch anything.
Yes.
And perhaps after
but this
3 or
would
4
work
waves,
perfectly if there is a leakage in the obturator leak point. But sometimes there are other leak points. I actually have a publication on this. Sometimes when you go, it's through the inguinal, through the this is only through the leak point, the obturator. But sometimes when you inject it, the labia, it's all going towards the pelvis, and nothing is going towards the lower limb. You know what? Sometimes
no, of course. If I inject there, I only want to close these lots of little veins coming down from the labia, and then of course I treat the leg.
Yeah.
I treat the leg. I don't not only do this, but it is wonderful if you know about the obturator point and the inguinal point and so on. These were very well described. And the problem in Germany is I have no surgeon experience in closing them, because if you have real large obturating points or inguinal points, it would be best to close them over these perineal points. There are very good results by Roberto De Frate, but I don't find a surgeon doing this for me. And I'm not a surgeon. I'm the investigator, and I do foam sclerotherapy. So I have learned that I can manage most of them with foam, and if not, I send them to retrograde sclerosing via endoluminal catheters by a radiologist.
Yes. Thank you very much.
Thank you very much. So, any questions, Dr. Ehab? Do you have a question, Dr. Ehab? Professor Muhammad, have a question? No. Professor Muhammad, please.
Thank you. I'm a vascular surgeon.
Yes.
I just have one question concerning the reflux detected only by elevating the lump of the patient and then standing up, and then you detect the reflux in these patients.
Yes.
As I've understood from you that after a while, if I repeat the test without lump elevation, there will be no reflux also. How this will affect our decision as a vascular surgeon?
Yes, very good question. I do this in the patients that have clinic symptoms of varicose disease, and I don't find the reflux. And as I told you, this is usually female patients with soft tissue, very soft, and they have edema, and they have pain in the ankles, and compression helps, and you don't find the reflux. And if you do this, if you go to the physics, a short reflux doesn't bother the transmural pressure as much as a long-lasting reflux, because all the time the reflux is running, you have a higher transmural pressure, and possibly this provokes edema. So I treat these patients when I see that they have edema, that they wear stockings and this helps, but they want to get rid of them and so on. If I find this reflux, they are so happy if you get rid of this reflux. Often it is a very tiny red surface when you can foam it, or you can laser it, or you can strip it, or do whatever you want, because this relieves their pain. And so I document this long-lasting reflux, which is evident that there is a reflux. But when the vein is like filled, it is only a little bit of moving of the blood, but the pressure is very high inside. I mean, I never made a bloody pressure measurement, but the clinics are showing this. And I sometimes think, oh, I won't treat it because it's such a tiny great saphenous vein, and there is nearly no reflux. And it is really good to help these patients to put them lay them down, put them standing, make this dependency maneuver. And if you find this reflux, you will help them treating the great saphenous vein.
Thank you.
They usually have not so much visible tributaries. It is only the great saphenous vein from the top to the bottom refluxing, and ankle edema.
We have another and last question from the panel. Dr. Ehab, please.
Professor Erika, I really enjoyed very much your wonderful presentation. I have two very small questions. Post-foam sclerotherapy, what is your recommendation for elastic stockings? How long and to which level? That's my first question. My second question is, if in case you have a DVT recanalizing, not fully recanalized and you're having a reflux in the superficial system, would you manage this after complete resolution of the DVT? And if there's a reflux after complete resolution, would you still embark on managing the great saphenous vein reflux?
Okay,
Thank you.
very interesting questions. The first one is easier. The post-foam sclerotherapy, I always use stockings because there is one little study saying that they have less pain, but this is empirical because I'm afraid there are not good studies to show this. I tell them to wear compression stockings class 1 or 2 in Germany, which is 2 or 3 from the rest of the world, which means either 15 to 20 millimeters at the ankle or 25 to 30. And I always have them to wear the stockings above the highest level I make the sclerotherapy. If I start in the groin, they have to wear panties. If there is something at the thigh, they have to wear until the groin. And if it's only at the calf, you can have the knee stockings. And I tell them to wear them 2 or 3 weeks. And I always explore them after 3 weeks for this sclerothromby. And then we make a little puncture and express these sclerothrombies to have them getting rid of them earlier. And then if they have complaints and there are lots of sclerothrombi, I tell them to wear them 2 or 3 weeks longer or then they can get rid of them. This was the first question. And the second question, I never treat a varicose vein while thrombus is resolving. So the varicose vein is always the second choice. And then if I really have a reflux, there you have to be very keen on, if you have a reflux in the popliteal vein, for example, usually it goes out through a perforator to the superficial vein. And then this is one of the little and only cases where I think you should close this perforating vein, because with this, you stop a little bit of the reflux in the deep vein. And I'm very, very cautious treating superficial veins in patients that have deep vein thrombosis, because they could need the superficial vein as a bypass. And as you perhaps know, I'm always doing the saphenous vein sparing techniques. So I try to, for example, if there is a deep reflux and also a great saphenous reflux, they profit if you make a crossectomy or you close the great saphenous vein with a short endoluminal closure and leave the rest of the vein there just in case they need it again. For surgery or for the own drainage if the deep vein closes. And I do this like after half a year to a year of the thrombosis, not earlier.
So, Dr. Mendoza, I have a short comment for you. So, you know, here in Egypt we have hot climate. So, the compliance with the patient for wearing stockings, it's very difficult to
I know.
Yeah. So, in your opinion, do you think that will affect the outcome of the treatment after foam sclerotherapy or other treatment options? If we shorten the time or...
Yeah. The thing that is demonstrated is that you have less pain if you put stockings. And I always, I come from Spain and I learned my phlebology in Spain, and there in the hot climate they won't. And I always tell them, if you put the stockings on, you have less pain, and you can, after putting it on, making it wet, because then you have a cold feeling in the leg. And I'm very convinced of compression stockings, but I'm sure nothing horrible will happen. Just that the convalescence time will be a little bit longer. But I mean, if patients prefer not to wear, I wouldn't decline a treatment because they want to have the compression stockings.
Okay. Thank you very much. We appreciate your precious time, giving you all this time from your busy schedule. I know.
Thank you for giving me this long time.
Yeah, we appreciate that you want to come on online. I asked you for a recorded lecture, but you asked I want to be interactive and common. We really appreciate this. We hope to see you in the very next conference and meeting in person if you can.
If you want, I would propose the topic of perforating veins exploration, which is very important, but it was
very interesting topic, and I think me and all the audience will be interested to hear this about.
Perfect.
Thank you very much.
Good luck to everybody, and
thank you
good
very
health.
much.
Thank you. Bye bye.
Have a good, lovely day. Thank you very much.
Thank you. Thank you. Same to you.
Bye bye.
Bye.
So now I'm